very good morning to everyone. Welcome back to another episode of Breakfast at UMHealth live webinar. I'm Karen and I'll be your moderator for this 12th episode. Breakfast at UMHealth is an online CME organized by the Visibility Unit, Faculty of Medicine, University of Malaya, that aims to provide relevant clinical updates to busy clinicians and other healthcare professionals wherever they are. So ladies and gentlemen, today we are privileged to have with us an oral and maxillofacial pathologist, Professor W.M. Tilakaratne, who will be sharing with us on oral potentially malignant disorders, OPMD. Before we begin, allow me to kindly introduce our speaker this morning. Professor W.M. Tilakaratne is currently a professor attached to the Department of Oral and Maxillofacial Clinical Sciences, Faculty of Dentistry, University of Malaya, and Department of Oral Pathology, University of Paradena. After completing BDS from University of Paradena, Sri Lanka, he obtained his MS degree from University of Colombo. Then he obtained his professional qualifications from United Kingdom and PhD from Japan. He has been working as an oral pathologist for 3 decades and held many positions in the field of oral pathology. He is a past president of the International Association of Oral Pathologists. He has worked as the Professor of Oral Pathology at Queen Mary University of London and a visiting professor to many universities in different countries. He was the former Dean and Senior Professor of Oral Pathology, Faculty of Dental Sciences, University of Paradena, Sri Lanka. Professor Tilakaratne's main research field is oral cancer and OPMD. He has published over 145 papers with a H index of 35 and written a textbook and contributed to many chapters in internationally recognized textbooks. He is an editorial board member for the latest World Health Organization WHO classification on head and tumors and oral cancer prevention handbook by IARC WHO. With that, let's put our hands together to welcome Professor Tilakaratne to share his talk with us this morning. The screen is yours, Prof.
Thanks, Karen. Let me share my screen. Right. Good morning, everybody. First, let me thank the organizers for inviting me to share some of our thoughts about this important disease category, oral potentially malignant disorders. Now, I'll be talking about different types of oral potentially malignant disorders or precancers, and some issues in relation to epithelial dysplasia, because that is the indicator for the clinicians to manage these patients, and some of the controversial issues, if time permits, in relation to OPMD. Now, what is the definition of OPMD? OPMD, or oral potentially malignant disorders, are clinical presentations that carry a risk of development of cancer in the oral mucosa. It could be either in a clinically definable precursor lesion or in clinically normal oral mucosa. Now, this is the last WHO classification. Now, this is the chapter on oral potentially malignant disorders, which we as a group contributed to. Now, as you all are aware, the WHO time to time published the classification books for different parts of the human body. For the head and neck, the latest classification is about to be out. That's the 2022. Now, but we have now come up with a full issue of head and neck pathology journal on various chapters of the WHO Blue Book. Accordingly, we have a couple of weeks back published this article on head and neck pathology on various chapters in the oral cavity section of the WHO Blue Book. And there we classify OPMD as a heterogeneous group of clinically defined conditions associated with a variable risk of progression to oral squamous cell carcinoma. Most of them produce clinically visible lesions. So that is the latest classification that we have come up with to define oral potentially malignant disorders. Now, as some of you may be aware, in the human body, we recognize the disease category called precancer. It's common to most organs, most the mucous membranes in the human body. Similarly, in the oral cavity, we used to call them precancerous lesions and conditions, but we changed the terminology in 2005 in a meeting we had in London to oral potentially malignant disorders. Simply because when we use the term pre-cancer, we are expecting almost all of them to undergo the malignant transformation, which is not the case in oral precancers. Only a minority of them transform into cancer. And also, this has been shown by laboratory, epidemiological, clinical, and various different types of studies. But they all have the attributes of a precancer. They have molecular changes, most of them to become, showing the ability to become cancer. So therefore, they all have a potential. So accordingly, we renamed precancer as oral potentially malignant disorder. Now, there are some important facts that we need to be aware of OPMD. Most oral cancers precede some form of OPMD. This is the most important, the information, the message that you can take from this lecture. Why we need to know about OPMD or precancer is because some of them transform into cancer, and if we do diagnose OPMDs, we can perhaps prevent them transforming into cancer, or we can diagnose cancerous transformation at a very early stage, reducing the mortality and morbidity of this very the cancer that the clinicians find very difficult to manage. So therefore, early diagnosis of OPMD, as I said earlier, reduces the incidence of oral cancer. And only some OPMDs transform into cancer. Transformation rate is not similar to all different types of OPMDs because there's a wide range of oral potentially malignant disorders. The transformation differ from one lesion to the other. Now, whatever said and done, despite all the molecular diagnostics available today for clinicians, when it comes to OPMDs, the grade of epithelial dysplasia with hematoxylin and eosin sections is the main indicator or prognostic indicator or predictor of prognosis and management, giving some guideline to the management of this heterogeneous group of lesions. Now in 2017 classification, now this is the list of the OPMDs, starting from erythroplakia, Ligoplexia, Lipoplasia, Submucous fibrosis, dyskeratosis congenita, smokeless tobacco keratosis, lesions associated with reverse smoking, candidiasis, especially chronic lesions of candidiasis, lichen planus, DLE, syphilitic glossitis is exceptionally rare, and actinic keratosis. So you can see a whole range of oral potential malignant disorders. Now this is the 2017. As I told you earlier, we have just compiled the latest classification of WHO head and neck tumors. There we have added some of the lesions which you did not have in the 2017, like oral Lycanoid lesions, oral graft versus host disease, etc. So they are, and the proliferative varicose Ligoplexia was also not there, but we know it is a very significant sinister OPMD. So we included all those also into the OPMD list, and especially the cancer syndromes, familial cancer syndromes, that is, like Fanconi anemia, dyskeratosis congenita, xeroderma pigmentosum, Li-Fraumeni syndrome, where you have inherited p53 mutations, Bloom syndrome, Cowden syndrome, etc. So now this is a comprehensive list. This book will be, the new classification book will be out in a couple of months, but the online version was out last week. So those who are interested to read about head and neck tumors can subscribe that WHO book online. until such time that the printed version is out. Now, why these OPMDs are so important to clinicians, as I alluded to earlier, because they transform into cancer. Now, the transformation rates are different. Now, if you take the Ligoplexia, the commonest one, the white patch, 9.5 or close to 10% is the overall malignant transmission rate, but the annual rate is about 1.56. That is a significant amount. Oral submucous fibrosis, the commonest OPMD in South Asia and to some extent in Southeast Asia, including Malaysia, the transformation is about 5.2. And the PVL, it is a special type of Ligoplexia that has almost 50% of transmission rate. That's exceptionally significant. Lichen planus, all my medical colleagues are so familiar with because it's very common in the skin, common disease entity for dermatologists. Now, this is a controversial thing even at the moment, whether it truly transforms into cancer or not, but according to literature, about 1.4% transform into. And erythroplakia, a rare lesion, we don't have enough literature to come up with the very correct transformation rates, but it's a very sinister lesion, or most of them transform into cancer. And the newly added OPMD, the lichenoid lesions, 3.8% of them transform into cancer. Now, these lichen planus, lichenoid lesions, graft versus host, now all those similar entities, some people would like to label them as lichenoid diseases. Now, this is the natural history. If you look at OPMD transforming into cancer, now these are the two common OPMDs that we see in this part of the world. Oral submucous fibrosis, you see the morbidity these patients have, even with the clinical pictures. They can't put the tongue out, they can't open the mouth, the mucosa is completely altered, it's like a leather. And with time, they transform into cancer. And a lot of these patients present to us in a very late stage, stage 3 or stage 4, 70% of them with metastatic disease, etc. Ligoplexia is again the same. And clinicians can't do much when they present at this stage. So therefore, the motivation of health professionals should be to diagnose them at the stage of OPMD. Otherwise, we end up with things like that. We receive this kind of specimens in the laboratory, pathology lab. With the whole mouth is out, you see the whole lower jaw and all the supporting soft tissue structures are out, including tongue. And the reconstruction is very difficult, and it takes 20 hours almost for the reconstruction of this. So in order to avoid this kind of mutilating surgeries, luckily we have the reconstruction microvascular flaps now, but in order to avoid this kind of major surgeries, diagnosis of OPMD is a must. Now, this under the microscope, the natural history of these things, you start with normal mucosa, then you get a thick layer of keratin like this on top of the surface epithelium. This lesion look like white, and then alterations in the epithelium, mild dysplasia, and then alteration in the lower and middle part of the epithelium leading to moderate dysplasia, and the full thickness of the epithelium is altered. You can compare that with normal epithelium. So that's called severe dysplasia, and it transforms into cancer. But the problem of managing, having protocols for the management of these OPMDs, you can imagine now all these different stages of OPMD can transform into cancer. Even we know in the normal epithelium, development of the oral squamous cell carcinoma, and from keratosis without any dysplasia, mild, moderate, severe, etc. So therefore, the management plans are very difficult the treatment protocols are very difficult to be drawn for OPMDs. Even the molecular wise, it is the same. Now, this is this paper came out from a world workshop we had some time back. And there we again identify the similar thing. You have the normal epithelium, you have potentially malignant lesion, and then some of these lesions are molecular-wise or biologically benign. So we cannot identify a lot of alterations. But some of them are biologically pre-malignant because some of the signaling pathways, the various molecules associated with carcinogenesis are either up or down regulated. And some of these lesions get dysplasia. some dysplasias progress into cancer, some do not progress. And so you can see how complicated the scenario of oral potentially malignant disorders. So therefore, the most important thing is to diagnose them, identify them as early as possible. Now, this is the flowchart that we just prepared for the WHO Handbook on Oral Cancer Prevention. Again, I'm trying to show you the same scenario, how complicated the OPMD natural history. The normal mucosa, you have potentially malignant disorders. Some of them get epithelial dysplasia, some regress, some don't progress, some progress, right? Then it goes through this cascade of events, the mild, moderate, severe, and they again, with the withdrawal of habits and various other interventions, you can revert moderate dysplasia into mild and severe into moderate. And so you can see how complex this story is. But whatever said and done, when it comes to oral squamous cell carcinoma, this is one of the cancers. The regional metastasis is very common in cervical lymph nodes and then into distant metastasis into liver and lungs. So therefore, it is very important to understand this dynamics of oral potentially malignant disorders. Now, you can see this keratosis without dysplasia to severe dysplasia. Some of these patients stay static. So identifying these static groups versus progressive group is the challenge for the researchers. Now, we look at some of the common the oral potential malignant disorders now. This is called Ligoplexia. It's defined as predominantly a white patch, which cannot be classified as any other definable diseases. So that's very important. If one wants to diagnose the Ligoplexia, we need to exclude all other similar diseases, which I will show you now. Now, these are the white patches, the Ligoplexia on the tongue, on the commissure, again on the tongue, commissure with white and red, that's called erythroligoplexia, and a very plaque-type leucoplegic patch on the tongue and on the buccal mucosa. So they are the clinical presentations of Lipoplasia. Now, Lipoplasia clinically we divide into different types. The homogeneous, they are very uniform in appearance, as most of the lesions I just showed you, and the non-homogeneous, and then proliferative varicose leukoplakia, that is the lesion that you need to be aware of because the majority of them transform into cancer. Palatal keratosis of reverse smoking, this is a very unusual habit that you don't see in Malaysia, you don't see in many parts of the world. You see that mostly in India, in one state called Andhra Pradesh, the females usually engage in this habit. And you see this in perhaps in some of the Pacific Islands and also in some tribes in Africa. So I told you the definition of the leukoplakia earlier, and this is homogeneous leukoplakia. You see the out of the subtypes, so it's a homogeneously white area of the oral mucosa. Right? Some of them with time get corrugated appearance or exophytic appearance, the nodule appearance or verrucous appearance, but most of them are flat white patches. But non-homogeneous leukoplakia has a higher chance of malignant transformation than the previous one, the homogeneous leukoplakia. There, here, what we refer to is you have the white patch within which you have red areas like that. Here, like that, the red areas admixed inside the white lesion or around the white lesion. Now, conditions that one should exclude before diagnosing leukoplakia are these. You can see the whole list. Clinicians should be very aware of these things, otherwise you are going to misdiagnose one of these lesions as leukoplakia, because most of these lesions have definite diagnostic features and also definite management guidelines. Oral lichen planus, lichenoid reactions, graft versus host, I told you, some would like to call these as lichenoid disorders. White spongineous, hereditary or familial disorder, frictional keratosis, chemical injuries, then candidiasis, both chronic hyplastic and pseudomembranous, lipoedema, Fordyce spots, that is ectopic sebaceous glands inside the oral mucosa, the skin grafts, oral hairy leukoplakia, very sinister oral manifestations of HIV/AIDS, nicotinic stomatitis, and those people who have chronic renal failure can get, you may not be aware, they can get white patches in the oral cavity. They are called uremic stomatitis. So one needs to exclude all these things before diagnosing lipoplakia. So these are some of them. This is, you see the diffuse patches. Now these patches can be removed. That is called pseudomembranous candidiasis. And this is another white patch. You see it is, you can demonstrate the presence of candidal hyphae in this. That is chronic hypoplastic candidiasis. And this is white spongineous, the autosomal dominant, the hereditary disorder, where you get usually bilateral involvement of very widespread white lesions. And this leukoedema, you get just white tinge with some blackish areas as well, but it's not difficult to differentiate from leukoplakia, because once you stretch the mucosa, the white color disappears. That's called leukoedema. And these are very common things that due to trauma, the frictional keratosis. Once you remove the cause of irritation, they usually disappear or start to disappear in 1 to 2 weeks. And these are the lesion that I was talking about, present in HIV/AIDS patients, called hairy lipoplakia, caused by Epstein-Barr virus. And this is the common lesion, oral lichen planus. Lichen planus, when it occurs on the tongue, they can be homogeneous or plaque type. So that can have the similar appearance to oral lipoplakia. Here you can see amalgam restoration, a filled tooth. Now these amalgam are notorious material to cause Lycanoid reactions. Now this Lycanoid reaction is due to this amalgam filling. And this case of a smoker, you see the palate is involved with whitish areas with red nodular appearance. That is called nicotinic stomatitis. So one has to exclude all these lesions before embarking on the diagnosis of lipoplakia. Now the lipoplakia, remember the important thing is the histopathologically it could range from just keratosis without any dysplasia to frank carcinoma. So that is what you need to remember. That is why once you diagnose a lipoplakia, it is better to have a biopsy to have the baseline information for you to have the management plan. Now, the problem that we face with lipoplakia are the surgical intervention does not appear to prevent them transforming into malignancy, so that's a difficult problem. Clinical type of lipoplakia and size are related to malignant transformation. When they are usually more than 200 square millimeters, according to research, they have a higher chance of transformation. Non-homogeneous type has a higher transformation, as I told you earlier. And the demarcation, presence of epithelial dysplasia and surgical intervention appear to be insignificant in terms of malignant transformation. These are the risk factors: the female gender, longer the duration, higher the chance of transformation. Leukoplakias in non-smokers, the idiopathic leukoplakias, the sites such as lateral tongue, floor of the mouth or palate, the size I told you earlier, non-homogeneous type, presence of dysplasia. The higher the degree of dysplasia, the more the chance of transforming into malignancy. Out of all the molecular markers people have tried, now these two things we know have a relationship to malignant transformation: DNA aneuploidy and loss of heterozygosity in different genes. Now, PVL is the important type of leukoplakia that I told you. It is first described by Hansen in 1985. Now, in short, what I try to say in this slide is, if you see multiple white patches in an elderly female patient, what you should expect is to have the diagnosis as is proliferative verrucous leukoplakia. Why this is more important? Because a large majority of them, more than 50% of them, transform into cancer. Etiology, we do not know the etiology for sure, but some people doubt about human papilloma virus, Epstein-Barr virus, some significant relationship, but still we need a lot of research. And we don't see a direct relationship between tobacco, arecanut, or betel quid with PVL. So they have different stages: flat patches, diffuse the focal white patches, then they become exophytic and verrucous, and they develop into squamous cell carcinoma later. There are 4 stages to proliferative verrucous leukoplakia. I will show you here. Now you see they start as flat patches like that, and with time they get verrucous appearance like that, and more verrucous appearance, and then it transforms into cancer in about more than 50% of the cases. Now, when you look under the microscope, this is what you see in different stages: flat stage, and then you start to get verrucous appearance, more verrucous appearance, and then they transform into cancer. So again, in other words, if you see multiple white patches in elderly female patient, this is the first differential diagnosis that one should consider. How do you diagnose these all kinds of lipoplexias? Of course, yes, the surgical biopsy is the most important one, as I told you earlier. It should be a representative biopsy. Now, if the lesion is large, like in PVL, multiple lesions, you can do multiple biopsies. If you look at this lesion, large lesion, you don't know exactly which area is the transform area or about to be transformed. So multiple biopsy is not a bad idea. And cytology is not 100% reliable, but you can do adjunct techniques to decide the area of biopsy, the most suspicious area. Toluidine blue, I have no time to describe that in detail. Toluidine blue will stain the most dysplastic areas. And also the adjunct techniques like Wellscope. The normal tissue has autofluorescence, the inactive fluorescence for the normal tissues, that is lost when there's dysplasia. So the normal green fluorescence that we see in a normal tissue becomes dark or black. So then we know that area is the more suspicious area to be biopsied. Then the reverse smoking, the palatal lesions, you see how nasty this lesion is. It's a classic lesion that you get due to reverse smoking. Large majority of them transform into cancer. Luckily, we don't have this disease, this problem in Malaysia. Erythroplakia, you see there, this is again similar to leukoplakia. You need to, this fiery red patch in the oral mucosa, and if one want to diagnose this, you need to exclude all other red lesions which can be named, like your inflammatory lesions and all range of other red patches that you see in the oral cavity. You exclude all of them if you are left with a lesion that is erythroplakia. Why this is more important? Because when we get the biopsy, large majority of them are already cancer. About 50% of them are already cancer at the stage of biopsy. 40% of them are the severe epithelial dysplasias. We don't use the word carcinoma in situ in the oral mucosa now. And the transformation rate is very high. But we don't have much studies to talk about the details about this disease, because the studies are very less, because this lesion is very, very rare. This is what we see under the microscope. This red color is due to this. The epithelium is very atrophic in some areas, although other areas showing full thickness dysplasia. Now, the next disease that I would like to touch upon is oral submucous fibrosis. Now, this is a disease that I have dedicated most of my research time. We have published extensively on this subject. This is my definition of oral submucous fibrosis that you will see in the journal articles and textbooks. Now, this is a disease of this part of the world, mostly in South Asia, but to some extent in Southeast Asia. We see cases in Malaysia because this is associated with betel quid chewing or areca chewing. This is a potentially malignant disorder. Now, these yellow highlights are important. It's a chronic inflammatory disease. You see, one of the most basic pathological problems in the human body, but still we do not have a definite treatment for this. Now, researchers should open their eyes why this chronic inflammatory disorder do not have a definite treatment at the moment. Now, this is a disease with a lot of morbidity and to some extent mortality. The morbidity is mostly due to fibrotic changes. Now, the mucous membrane get fibrosed, replacing muscle with fibrous tissue, so they can't perform normal function, leading to a lot of morbidity. And most of these patients present with the burning sensation of the mouth, to spicy food. That is because of this feature, atrophy of the epithelium, thinning of the epithelium, because then all the nerve endings get stimulated for minor stimuli. And the most important thing in terms of the clinician, the health professional is this atrophic epithelium becomes dysplastic and it leads to cancer. Now we managed to get one whole issue of the American Journal of Oral Surgery or Medicine and Oral Pathology on this disease, which I edited some time back. So those who are interested can go to this issue and read all about submucous fibrosis. This was in August 2016. And this is the diagram that with our 3 decades of research, we came up with the symmetric diagram for pathogenesis as well as malignant transformation of submucous fibrosis. Now, this is the culprit, nothing else, the aricanate in different forms. All these, the aricanates have the same chemicals, especially aricoline and other alkaloids like aricadine, guaifenesin, guaiacol, etc. And also it has various polyphenols. So the IARC or International Agency for Research in Cancer of WHO has identified 4 carcinogens in aricanate, 2 coming from aricoline, 1 each coming from guaifenesin and guaiacol. So therefore now aricanate is labeled as a group 1 carcinogen in this volume 85 of the IARC monograph. What are the clinical features? The burning sensation, difficulty in taking spicy food, roughness of the oral mucosa. You can see this like cement, very leathery. Very early stage, you get vesicles, especially in the soft palate area, restricted mouth opening, difficulty in tongue movement, and you see the lips, everything blanched. So this is very characteristic of oral submucous fibrosis. All these features are due to fibrosis. Now, these are early cases, very subtle fibrotic changes. But with time, you see what happens. Now, these fibrosis extending into muscle. Now, these are this more eosinophilic or pinkish areas are muscle fiber bundles. Now, you see this fibrous tissue creeping in between muscle bundles, replacing them. Now, here more advanced. Now, you see the muscle is lost in a jungle of fibrous tissue, right? So these muscle fibers are very innocent. They can't do anything. That is why these people can't open their mouth. They can't move the tongue, etc., because the whole musculature is now replaced by fibrous tissue. The precancerous nature of this disease was first described by a person in India called the Paymaster in 1956. He identified about 1/3 of his cohort of 600 plus patients transforming into cancer. That is a very high figure that may not be very accurate, but he is credited for the description of malignant transformation in this deadly disease. And to make it worse, the large majority of them, about 25% or more of them, get Ligoplexia developing in submucous fibrosis. You see 2 OPMDs in one patient. That increases the chance of malignant transformation. Now, as I told you, the only indicator of management indicator of OPMD is the epithelial dysplasia. Depending on the study, you have different range of dysplasia, ranging from say 7 to 30% line. Malignant transformation, again, we have a wide range, but the most recent systematic review that we use for the WHO Blue Book is around 5%. Now you see the Ligoplexia arising in submucous fibrosis. They can't open the mouth, can't put the tongue out, but you have the white pad there, similar white pad there in a patient who can't open the mouth. And you see this depapillation is a very common feature of submucous fibrosis. On the depapillated tongue, you have a white patch. And this is the atrophic epithelium, very thin epithelium. There are no ridges, etc. But you see that with time, you start to get epithelial budding, right? Very tiny epithelial budding. That is dysplasia. That is the dysplasia. But in the context of other OPMDs, conventional dysplasia grading, this probably is not considered as a very significant thing. But in the case of submucous fibrosis, because it is arising from this flat epithelium, this is probably significant. So this is what happens. Now the mucosa is completely hyalinized and fibrosed. and you start to get dysplasia, and more dysplasia, even more dysplasia, and then it becomes cancer. Oral lichen planus. Now, this is for the medical fraternity, it's not an unfamiliar disease, or lichen planus, not oral. The lichen planus is a common dermatosis, it's a chronic inflammatory disorder. The etiology, various factors are proposed, but the definite etiology we are not sure of. It is a disease with a lot of relapses and remissions. A lot of lesions have reticle, they are the classic lesions, the reticular pattern in both the buccal mucosae. Sometimes you have atrophic, erosive, ulcerative, plaque-type areas, as I showed during the Ligoplexia. The lesions are usually bilateral. And more importantly, for the dental fraternity, one of the important things is they can purely present with discomative gingivitis without having other lesions. So these are the different manifestations. You see the reticular lesions in the buccal mucosa. And the pigmentation is also common in associated with lichen planus, again reticular patches. And you see the reticular areas as well as red erosive areas. And when the lips are involved, you see the pigmented lips with dryness and crusted appearance. And this is what is called discomative gingivitis for the medical fraternity. If you're not familiar with, when a patient presents like this, lichen planus is one of the differential diagnoses. Of course, there is a whole list of things why you get discomative gingivitis, but lichen planus is one of them. So you all are familiar with the skin manifestations. You get them mostly on the flexor surfaces. They can get as crusty patches like this, or sometimes rarely they can present with vesicles similar to other vesicular disorders. If you look at the malignant transmission potential of oral potentially malignant disorders, now we have some lesions of which are very sinister, like erythroplakia, proliferative verrucous lipoplasia, reverse smoking. So the malignant transmission rates are very high. Submucous fibrosis is not much far away from those things. So therefore, identification of these more risky oral potential malignant disorders are very, very important for both medical and dental and the allied health professionals. Now, I told you the most important parameter that we tell something about, some information about the management guidelines, how frequently they should follow up those patients, etc., by assessing the degree of dysplasia. Now, the dysplasia has a lot of problems. The management is a challenge, and the dysplasia grading is a challenge itself due to various reasons. I will show you some of them. So we came up with this review some time back, addressing most of the things that we identify in oral epithelial dysplasia. Now, in 2017 classification, oral dysplasia is defined as a spectrum of architectural and cytological changes occur due to accumulation of genetic changes, and these lesions are associated with malignant transmission or going into squamous cell carcinoma. We know the normal epithelium has a typical architecture, arranged architecture that gets altered, and we know the normal cells have different features. Those cytological features becomes abnormal when it comes to dysplasia. Now, because it's a mixed audience, I'm not going to elaborate more on this, but now this is dysplasia. Now you can see if you look at this lower third of the epithelium is different from the rest, so that the cytologically or the cellular appearance has changed. That's called cytological atypia, and the normal architecture of the structure is also different now. You know, the epithelium has stratum basale, the basal cell, stratum spinosum, conium, etc. in an epithelium. That is again altered in this. So this is restricted only to the lower area. We call it mild epithelial dysplasia. Now here it goes into the upper third, the middle third. So we call it moderate epithelial dysplasia. And here, if you look at its full thickness is involved, that is severe epithelial dysplasia. That's again full thickness is involved, but basement membrane is still intact. So therefore, it is not cancer because the hallmark of cancer is invasion. Invasion is not there. So these are severe epithelial dysplasia. These are like suicide bombs about to be burst. So any time it can breach the epithelium and go into the underlying connective tissue causing squamous cell carcinoma. However, we have various problems when we try to grade epithelial dysplasia. There is a massive inter-examiner variability. Right now, we are carrying out nationwide calibration workshop for all the Malaysian oral pathologists at the moment. We are into the third phase of that very soon. And it's very difficult to reproduce individual dysplastic features. Remember, there are 8 architectural and 8 cytological features, so they're very difficult to reproduce. And to make it worse, there are other features which can exaggerate the appearance of dysplastic features, like presence of candida. And there is no correlation, good correlation between grading and clinical behavior in some cases. And grading does not reflect the clinical extent of the lesion or severity of the lesion in this particular group called varicopapillary lesions, like varicose, coming into varicose carcinoma. So there are a lot of problems in dysplasia grading. So what you need to remember therefore as clinician is the dysplasia grading that you get for a particular OPMD does not necessarily tell you how that lesion is going to behave. So this is the 2005 classification where we had 5 categories. Like in your cervical epithelium, our medical colleagues are familiar with SIN or SIN 1, 2, 3. And similarly, 2005, they tried to introduce that to oral cavity, but it is SIN, squamous intraepithelial neoplasia, 3 categories, and this is the laryngeal classification. So, but this is not giving better reproducibility. So we have shown it in one of the studies because this 1/3 category SIN, or we call oral intraepithelial neoplasia, it does not work very well for the oral cavity. You can see when you take mild, all 3 categories are there in mild, moderate, also same. So therefore we recommended that this is not a good way to go about having the similar scenario as cervical epithelium. So in 2017 classification, we were part of the dysplasia grading again, and we came up with 8 architectural features and 8 cytological disturbances, and we added one feature that we thought a very important feature for dysplasia grading in any epithelia, loss of cohesion of epithelial cells, that we added in 2017. Some of our work helped for that. Now this squamous epithelium. So this is what is meant by lack of cohesion. You know, all those who are familiar with histology to some extent know these epithelial cells are attached together by desmosomes. Now here they are expanded and they are floating separately. Now if this happens in vesicular disorders or viral infection, these cells are dead, but these are not dead because they produce their own material, own extracellular matrix to survive within the epithelium that we have shown in this picture. Now these heparin sulfate proteoglycans in the dysplastic epithelium, so they are good enough for them to survive. So accordingly, we included that feature into dysplasia grade. So in 2017, we came up with mild, moderate, and severe, and also we introduced, like in the case of larynx, low grade and high grade dysplasia. But unfortunately, now to 2022, the classification that we are about to release, we have added some more features, I think making it even more difficult, because we had to do that because research have shown these newly added features are also significant features in the progression of dysplasia. So we had to add, but it is not making life easier for pathologists, even making it's a little more difficult. But that is the reality. We go according to what is available in terms of research. So therefore, the attributes of a good grading system should be to identify those lesions which can be kept under observation and those lesions which need treatment. And the lesion, the grading should be reproducible, minimizing intra and inter-examiner variability, which is not the case in the present classification. Very importantly, the grading should be biologically significant by identifying the lesions that are likely to undergo malignant transformation. From clinician's point of view, that is the most important thing. They are not bothered about reproducibility, etc., but they should know whether their given patient is going to transform into cancer or not. So I will touch upon some of the controversial issues in the OPMD. I told you the dysplasia grading is a big problem in oral submucous fibrosis. That's the controversy, whether we can adopt the existing dysplasia grading to oral submucous fibrosis is something that we need to ask. But these minor changes are not considered as dysplasia in other OPMDs. Now these lesions, now if I ask a question from the clinician, now what do you think about these lesions? You all might think they look like cancer, right? But when we look at it, hallmark of cancer is not there. You see, they are very exoptic lesions. They are not going into the underlying tissue. There is no invasion either. So because this submucosa is very fibrous in submucous fibrosis, probably this epithelium find it difficult to go inside, it comes outside. But they may have probably the malignant phenotypes in epithelial cells. Now, even this lesion, you see, I don't have any problem calling it squamous cell carcinoma, but this is the biopsy of that. Very exoptic, there is no invasion. Now, these are the controversial areas where what we should be calling them. And lichen planus, lichenoid reaction, lichenoid dysplasia, this is another territory where we have not reached consensus as to whether they are really the lesions with dysplasia or we diagnose these lesions as dysplastic lesions mistakenly as these entities with dysplasia, because any leukoplakia lesion, the white lesion, can have a lymphocytic infiltrate mimicking these definable entities. When they have a little bit of dysplasia, we call them as either lichen planus with dysplasia or lichen reaction with dysplasia. Whether it is correct or whether we are misdiagnosing lipoplasia with dysplasia as these lesions is a controversial issue. To make it even more difficult, now when you take lichen planus, for example, differential diagnosis under the microscope is enormous. It could be PVL or proliferative lipoplasia, lichenoid reaction. It could be DLE. It could be graft versus host. It could be chronic ulcerative stomatitis. It could be a genuinely dysplastic lesion. It could be even mucous membrane pemphigoid. All these lesions can mimic the appearances of lichen planus under the microscope. This is mucous membrane pemphigoid. You see the band-like lymphocytic infiltrate. Bullous lichen planus can have the similar appearance. So this just to show how similar the lichenoid reaction and lichen planus under the microscope. This is one lesion. I'm about the last couple of slides. Now this is chronic hyplastic candidiasis. Now this is one of the lesions where we have to be very careful. When there is candida on the OPMD, dysplastic features can be exaggerated. So that is something that clinicians should remember. So it is simple. You can do a simple swab and do PAS or periodic acid shift, and you can identify fungal hyphae and then treat with antifungals and then do a biopsy to grade epithelial dysplasia. Otherwise, you end up with exaggerated dysplastic features, giving a higher degree of dysplasia, and patient will have over-treatment. Because a lot of these OPMDs can have candidal superinfection. So you have to eliminate. One good example is when you follow up a homogeneous white patch, one visit, patient comes with white and red areas. It could be due to one of the two things, either malignant transformation or candidal infection. So first you should eliminate the possibility of candidal infection and then think of doing a biopsy to exclude malignant transformation. So therefore, my dear friends, the take-home message for all of you is this: the proper understanding and early diagnosis of oral potentially malignant disorders help in reducing the incidence of oral cancer. And this is mandatory for all the health professionals to have some understanding about oral potential malignant disorders. That helps to reduce the morbidity and mortality of oral cancer. Because diagnosis of oral cancer at stage 3 or stage 4, which is the case now for 70% of the cases, is not going to help the patient. If we are aware of OPMD, with all these things are visible lesions, we all look at our mouth, and if we can diagnose them as at OPMD stage, so oral cancer may not be a big health burden. Because this can be done by all the health professionals, irrespective of you're a medic or a dentist or the paramedic, they all can do this. The nurses, etc., everybody can do this. So therefore, please be aware of this very important disease category called oral potential malignant disorders. Thank you very much.
Sorry. Thank you, Prof. Tilak, for the insightful sharing on OPMD. I just felt like I have attended a crash course in this 50 minutes lecture, which is very, very useful, very informative. Okay, so now the floor is open for some Q&A, question and answers session. So if anyone have any question that you want to ask Prof. Tilakaratne, please feel free to type in the chat box or the Q&A.
Yes.
We have one question here from Prof. Ian Patterson. And he said, a few years ago, a paper in Cancer Research reported that P16 promoter methylation was an accurate predictor of progression in dysplasia, which appear very promising. Are there any follow-up studies?
Thanks, Ian. Yeah, it's a good question. Yes, I'm aware of some studies on P16 promoter methylation. I think if I'm correct, even recently there was a discussion in one of the forums about, we have now HPV associated dysplasia as a separate entity of dysplasia in the oral cavity, which will appear in the upcoming WHO Blue Book. In that cohort of patients, I guess this is even more true. Yes, this is a good area, but we need more work in. So especially now that we have this very specific HPV subset of Ligoplexia, now this is a good area to do research. But at the moment, we don't have very solid, concrete the findings.
Anyone else? And any question from the floor? Okay, I have a question for Prof. Recently, there is a group of researchers in Queen Mary led by Dr. Tech, and he was he claimed his team claimed that they just have to take a little bit of a tissue, a 1 mm small size tissue, subject to some qPCR analysis of some of these gene signatures markers that they found, and some algorithm, and they come up with this quantitative malignancy index diagnosis system, QMIDS in short. And they say that it's really accurate to predict, which, when they have pre-malignancy, whether they transform and they don't. So what are your comments? Like, will they be a replacement to, to some of these features we have just mentioned in your talk?
Thanks, Karen. Actually, it's very good. And I'm aware of this paper and I read it actually. It's very promising.
Yeah.
Tech Day is, when he was young, he was my co-researcher. When I was at Queen Mary, actually, he was one of those people who did the original work on HIF1 alpha in OPMD for the first time with me. Actually, I spoke to Tech after I came to Malaysia, after seeing this paper. Somebody forwarded this paper. Actually, I asked him, I went one step further and I asked him whether your sample had beetle chewing habit, where they have done it using their patients, so without the similar habits to the patient in this part of the world. I wanted to see whether that works for our patients in this part of the world, and I proposed him whether we can do the same, try the same using our samples here. He agreed for that, but unfortunately we could not progress. Yes, Karen, that is something that we can do because Tech is, he's from Malaysia.
Yeah, yes,
He's from
yes.
PJ. He comes to Malaysia every year. So
Yeah.
I think he's somebody that we can ask to collaborate. He's very much willing to collaborate with us.
Yes, yes.
So good that you reminded me again. So we will contact him and we will try to adopt his technique to some of our samples,
Yeah, exactly. Some
especially
of the work.
beetle chewing habit related.
Yeah.
Yeah, according to what they have presented, they can predict with a lot of accuracy. Yeah.
Yeah. Okay, good. Promising. Okay, there's another question from Dr. Yap. Her question, what is your comment on the association of EBV infection? What is the mileage for some investigation to confirm this?
Thanks, Lifa. Yes, you know the involvement of Epstein-Barr virus in oral lesions is not unheard of, not something which is very new. So even when it comes, as I showed you, when it comes to proliferative verrucous leukoplakia, some people think there should be, in addition to HPV involvement, there should be some involvement by EBV. But again, unfortunately, we do not have enough studies on EBV and OPMD. We have some papers. But if you ask me what I feel right now, but conventional leukoplakias and other OPMDs, I have no scientific evidence, but I doubt whether there's a definite EBV involvement. But again, with the reply to Ian's question, now as we are recognizing and describing now the special subset of leukoplakias with HPV involvement, I think that is the subset of oral lesions, OPMDs, that we need to look for EBV involvement as well. Yeah, that's the good thing that we should actually look into.
Okay, that's another question in the chat box. It says, regarding verrucous hyperplasia, although many researchers consider it as OPMD, but still not included in WHO due to lack of data. What is your opinion on this?
Say it again, Karen.
I say, regarding verrucous hyperplasia.
Oh yeah, I see that. Yeah.
Yeah.
Although many researchers considered it as OPMD, but very interesting question actually. We were talking about this last week because we just completed a systematic review on verrucopapillary lesions. Now, why verrucous hyperplasia did not come into WHO Blue Book? Very good question. Time, I also thought the same way. Why it didn't come? Because if you look at the original paper of verrucous hyperplasia in early 1980s by Pimborg and Scheer, 60% almost of the verrucous hyperplasia had dysplasia. But then, as you correctly say, why it did not come into OPMD list? The problem is, now the nomenclature is not very definite, up to date, although it has gone many decades now. Whether verrucous hyperplasia is another different stage, a clinical stage of conventional leukoplakia, whether it is another stage of, we know it is a stage of proliferative verrucous hyperplasia, leukoplakia, whether some of those lesions are, some people call verrucous leukoplakias, those, very many entities are there. Now, to add into verrucous hyperplasia list, we have another lesion we described in, especially we did it from Malaysia actually in a workshop, Asian Consortium, exophatic verrucous hyperplasia in OSF patients. They all share similar appearances. So whether verrucous hyperplasia is a manifestation of different disorders at different stages is something that people query and doubt. So therefore, it did not come to OPMD list. Whether we should reserve verrucous hyperplasia for those lesions which have verrucous appearance but there is no dysplasia is another school of thoughts. But for WHO Blue Book, the upcoming one, we have included because we have research from some people. Verrucous appearance is a dysplastic feature. So, willingly or unwillingly, we had to include the verrucous appearance as one of the architectural disturbances of epithelial dysplasia. Yeah, that is a complex area, but I agree with you. This is something that we need to take into consideration to sort out this matter. One of the reasons why we came up with this systematic review also, whether we can get the nomenclature correct for these different verrucous lesions. But according to literature, it is not the case. We cannot come to a definite conclusion as to whether verrucous hyperplasia should be included as a definite separate OPMD.
Okay, thank you. That's another question from Dr. Amara. She asked, how do we distinguish between candidiasis and cancer relative to the progression of tissue analysis?
How do we distinguish between candidiasis and cancer relative to the progression of tissue analysis? Can you elaborate a little bit more on this question? I don't understand very well this question. Amara?
Are you there? Amara, can you elaborate further on the question? Do you want to speak? I can unmute you if you want to ask directly.
Okay, I will shed some light on that, at least in relation to that. Now, I told you candidiasis. Now, unfortunately, this time the candidiasis was dropped from the list of OPMD, which I think I forgot to tell you. We added new entities and we dropped candidiasis, chronic hypoplastic candidiasis or chronic candidiasis as a possible OPMD, simply because, again, we do not have enough literature on that, scientific evidence on that. We do have some evidence to say the candida can help in transforming the ethanol into acetaldehyde, which is a carcinogen. So there are a couple of studies on that. But other than that, we do not have solid evidence to say how the candida help definitely in transforming, especially the candida-induced lesion, whether it transforms into cancer definitely because of the etiological background. We don't have enough literature again. So therefore, we had to drop chronic candidiasis this time from the list. But one thing for sure, the candida can increase the appearances of architectural and cytological atypia. So that is why whenever there is candida in a biopsy with dysplasia, we do not give a definite grade unless the clinicians treat for candida and do a rebiopsy. Because once they do the rebiopsy, one of the two things can happen. With our experience, sometimes the lesion completely disappears. So that tells us it is of candidal origin. Or the dysplastic features reduce in their extent, so the dysplastic features, the severity reduces. So that those things we have identified. But whether candida itself is driving towards cancer carcinogenesis is not sure. So when we look at the tissue, of course, it is not a difficulty to differentiate the candida from cancer. That's not a problem at all. But the presence of candida in OPMD is the more important issue, right? So that can have implications in dysplasia grading and also the etiopathogenesis aspects.
Okay, hope that answered the question from Amara. Okay, there's another question from Dr. Izian. As pathologists, what will be our consensus in diagnosing cases of oral epithelial dysplasia with lichenoid inflammation, since the term lichenoid dysplasia is still controversial?
Right. Thanks, Isyan. Now, yes, this is again an important area. You know, the term lichenoid dysplasia, I personally don't like. A lot of experienced pathologists feel the same way. And when there are inflammatory changes, you know, it can induce dysplastic changes is something that we all are aware of, the relationship between inflammation and cancer. So that is there. But one of the things that happened recently drastically in relation to this lichenoid features and dysplasia is the fact that according to American Academy of the Oral and Maxillofacial Pathology, now they consider the presence of dysplasia is an exclusion criteria for the diagnosis of lichen planus. In other words, if you see dysplasia in a possible case of lichen planus with other supportive histopathological features, they do not diagnose that as lichen planus. They diagnose it as some degree of dysplasia, and the immune response or inflammatory is due to the presence of dysplasia. So they do not give the diagnosis of lichen planus for that. So that, yeah, that's a controversial area. But I rather would like to diagnose when you have dysplasia and inflammatory infiltrate, the definite grade of dysplasia, and that's it, rather than giving a label of lichenoid dysplasia or lichen planus or whatever. But I tend to diagnose, I have done that, but I still have the controversy in that when you have typical clinical picture of lichen planus, the bilateral, say to make it even worse, reticular lesions, and the clinician does a biopsy, and the biopsy shows mild degree of dysplasia, are you going to deny the diagnosis of lichen planus? But now, according to American guidelines, yes, it is the case. But I feel a little uncomfortable, and I'm sure then we should take off lichen planus altogether from the OPMD list. So that was also suggested. Because we know, although we talk about lichen planus, malignant transmission in the oral mucosa, it is not the case when it comes to skin. There are reported cases, but it is not a significant scenario among the dermatologists.
Okay. I think it's about time. That's all. Okay, we have come to the end of today's episode of Breakfast at UMHealth. Thank you so much once again to our speaker, Professor Dr. Tilakaratne, for his sharing this morning with us. And we hope many has gained new knowledge, and this episode has been an enjoyable and beneficial for all of you. So lastly, we would like to apologize for any shortcomings, and thank you everyone, and we look forward to seeing you again in the next episode of Breakfast at UMHealth. So thank you. Goodbye for now.